Coming to Presence Healthcare in 2007, Amy interned at the University of Minnesota's Center for Bioethics, was a clinical intern at Lutheran General Hospital in Park Ridge, and taught dental ethics at UIC Dental School. Outside of her work at Presence Healthcare, Amy is an adjunct professor at Loyola University Chicago in the Department of Philosophy, and is a member of state task forces concerning matters in healthcare ethics. Dr. Robert Sawicki, who will also be presenting at 1 o'clock on the topic of ordinary and extraordinary needs, palliative and hospice care perspectives, received his MD from Rush University and completed his residency in family medicine at the University of Illinois at Rockford. While attending Rush, he was an active member of the U of I Medical School Newman Center. He practiced in Bloomington, Illinois, where he served as the medical director for hospice. End-of-life care became his passion, and he drove the development of palliative care services, or OSF healthcare, in all of its hospitals, as well as advanced care planning process known as OSF Care Decisions. He is now the Senior Vice President of Supportive Care for OSF. He is board certified in family medicine with added qualifications in hospice and palliative medicine. He is married with 2 children, a son who lives in Manhattan and works in information technology, and a daughter who will be entering graduate studies in bioethics at Trinity International University this fall. The panel is rounded out by Lisa Anderson-Shaw, who is a colleague of mine here at UIC and eminently helpful in many ways, and her title is Ethics Consultant for all things bioethics that go on here at UIC. Who is beginning? Whoever doesn't have their mouth full, I suppose. You can panel, so why don't you stay where you're at?
I can sit and I can... Okay, is that on? Can you hear me? And you can hear me through the mouthful that I have. I was asked to give the perspective on POLST from the hospice and palliative care community. What I was hoping to accomplish was to give some notion of what is different about POLST compared to what we currently have. The state of Illinois, as you all know, is a very interesting political animal. We actually did not pass POLST legislation. We passed legislation to update the Illinois Uniform Do Not Resuscitate Advance Directive to become compliant with POLST guidelines. And that's a fine distinction, but it's actually very important when you think about it in a couple of different ways. First off, what we currently have is the Illinois Uniform DNR Form. And that was originally the orange form. I don't know if you're going through any of the history of that, so I won't belabor that. But it's a code or no code. Yes or no in the full arrest situation. In the pre-arrest situation, what is it that you want to do? And while there is a degree of flexibility with that current form, it's not to the extent that it needs to be. The POLST form itself, now, the Illinois DNR Form /POLST is more flexible, gives you a better perspective on what patients do or do not want. How that translates into the hospice and palliative care world is this. Let's say, for example, you are a hospice patient in a nursing home, and previously you would have a do not resuscitate order on your code form, your DNR form. You develop a fever at 2 a.m. What happens? The current state is that they send you to the emergency room, where, of course, you end up getting admitted to the hospital, IV antibiotics, and that may or may not be consistent with your wishes. With the POLST form, you are able to get into some of that level of detail of what you would or would not want. And again, going back to our earlier discussions this morning, what is proportionate to you as a patient? And it allows you to specify. The other key piece to this new document is that by state law, it must be honored by all medical personnel. So in previous state, if I were a patient with a DNR form and I showed up at St. John's Hospital somewhere, and I had a DNR form and that physician wasn't familiar necessarily with the signature of the physician, he could theoretically choose not to honor that DNR. Now he must, unless he has compelling reason to believe otherwise. And not just the code or no code, but the rest of the documentation as well. And Lisa's going to go through, hopefully, here shortly, some of the details of what is on the form and what's involved with that. The other thing that's interesting about the new form is that by specifying some of the things that a person may or may not want. When you talk about hospice, we know there's the hospice Medicare benefit. We know that it specifies that you provide certain things, including treatment for comfort, equipment, medications, etc. But as we all know, if you've dealt with hospice in any way, shape, or form, when you've seen one hospice, you've seen one hospice. And the hospice in one community may be very willing to provide intravenous fluids or tube feedings or other such things, whereas another hospice may find that financially prohibitive and not accept patients who are in certain situations as a result of that. This will help them understand and help them address with their patients what those wishes are, and hopefully be able to identify more appropriately who is appropriate for hospice care and who is not. Are you up and running? Okay, yeah, and
So, do you have
I reserve the right for a moment.
all right, very good. So I think I'm going to go ahead and get started without the PowerPoint. I apologize, we don't know what's going on with these computers, but they're kind of jumping around. So you've got the form in front of you, and so I'm going to go through each of the parts of the form with you, okay? So basically what Dr. was saying about the form is that it isn't a POLST form, so to speak. It's still the uniform DNR, or what we call the uniforms do not resuscitate DNR, advanced directive, physician order for life-sustaining treatment POLST. So that's why POLST is on the form, because we do comply with the POLST paradigm, the national POLST paradigm. So we can call it a physician order for life-sustaining treatment. This is replaced the old orange DNR form, which started around 2001, something like that. And then it evolved into a couple of revisions from the orange form, and now it can be on white paper, and it has a little border around there. So this is meant to look like that form because it has the border on it, so you can find it in the charts pretty easy. So historically, the POLST, or our uniform DNR form, promotes quality care through informed end-of-life conversations and shared decision-making. So it is more than just the DNR, or do not resuscitate form. And as you can tell from the front page where it has the A, B, C, D, and E, it isn't a checkbox. There has to be conversation, and it is a process. So that's what makes it also a little more useful to the first responders. And again, if you recall, the DNR out-of-hospital order form was really for first responders, EMS, folks that get to this house, they call 911, and the patient really doesn't want to attempt resuscitation, but they might have freaked out, called 911, wants comfort measures, but doesn't want CPR and full-blown ACLS. Right, so that's what makes this still a useful tool in those respects. But this goes a little bit beyond that, and it helps us then in the ER situation and beyond for the palliative care. It is a concrete medical order that is signed by a physician. So we do honor that. EMS must honor it by state statute as well. So again, this is a physician order. It's easily recognized by EMS because of the border. If we do decide, or if your institution does want to put it on a colored piece of paper, it's this pink paper that apparently does Xerox well or photocopy without a bunch of black marks on it. So you can do either that color or not. it's really hard for us to keep up with the pool paper. So at UIC, again, I'm sorry, I'm Lisa Anderson-Shaw, I'm the Director of Ethics Consulting Service here at University of Illinois at Chicago Medical Center. So we're used to electronic records, but the paper chart always has this copy in it for us, so it's easily recognized. And it also is portable. The form does follow a patient or a person from care setting to care setting, from home to care setting. So we'll talk a little bit about that. Now, in the United States, the National POLST Paradigm programs are really clustered in the East and the West and a little bit in the Midwest. But it is catching on throughout the country. The National POLST organization is in California. They have a wonderful website with lots of good and available free education materials. POLST Illinois, and Amy and Bob are both on our task force. This has been a labor of love over the last over a year and a half, where a group of folks from all over the state of Illinois and from all over different kind of care settings, palliative care, hospice, long-term care, social work, nursing, physicians. We have, everybody I think at the table for our state task force. We also have a leadership task force, and then we have all these subgroups. So it's very organized, I think. Oh my Thank you so much. I need one of my kids to help me take care of all this technology. You can help me. Thank you. So, again, there's our posting, and there are some objectives, so we do have a few things. And I know I have a very limited amount of time, so we want to make sure we have time at the end for questions. So the IDPH Advanced Directive is also called POLST now, we just talked about that. But it also is meant to reduce medical errors by making sure that the wishes of the patient are known, and that there is going to be this conversation with providers. And then I think we were at this slide here. This shows you can see the dark blue are endorsed programs. So there's a lot of endorsed programs throughout the country. The medium blue are those that are developing, and our new slide for this will be dark because we have a POLST program, even though our form is a uniform DNR order form. And then the ones in white have no programs. So you can see that this is really kind of a very useful tool, and once providers use it and they like it, it becomes more available in other areas. Now, what's the difference between an advanced directive like a power of attorney form and the POLST form, or the uniform DNR Illinois form? What's the difference? Well, the POLST form is really designed for those patients facing life-threatening complications, regardless of age, or patients with advanced frailty and limited life expectancy, and or persons who may lose the capacity to make their own decisions, you might think in the next year or so, or persons with strong preferences about current or anticipated end-of-life care. So we don't really define advanced frailty, but it's sort of like you know it when you see it. So it's for those patients too that you might expect would pass away in the next 6 to 12 months. So again, the POLST form is really to direct those end-of-life kind of care issues, and we're going to go through each of the sections on the form, whereas anybody can benefit from a power of attorney for health care. Most folks really over the age of 18 should kind of have some ideas, but most of us don't get there until we've had maybe an illness in our life. But that allows you to name the proxy for the decision maker. This allows the patient to have conversations with the team and their physician and get some specific orders written for their end of life. So here's the form. You've got a front page and a back page, right? And we're going to go through each little section. This is exactly the form that's on the IDPH website now. Okay? The old form has been taken off of the website. The new form is here. If you have an old form, or if we get the old forms that come through the ER or field hospitals or any institutions, we will honor those. It's not that they are obsolete any longer, but what we would like to do is encourage folks that have one to perhaps fill out a new one, the new uniform DNR order form. So we're going to go through each section. So, now I see okay, good. So the first section is section A. Now this is the section that has to do with the do not resuscitate or attempt resuscitation, okay? And on section A, you have 2 boxes, and you must choose one of those. Attempt resuscitation, CPR, or do not attempt resuscitation, DNR. So that in and of itself is like the old form, and that's what EMS is going to first look for, is that piece right there, okay? And that's important. Now, if you select attempt resuscitation, the first little box, this means intubation and mechanical ventilation, okay? When our task force was talking to the other folks in different states, looking at what problems that they had, that was one of the problems. Is some people say, well, I want CPR, but I don't want to be on the ventilator. And as an EMS or a first responder, that makes no sense. So we made it so if you want CPR or assisted, attempt resuscitation, then you get ventilation, okay? But if you don't want anything, then that's what we'll honor. So that's section A. Okay? There's multiple kinds of emergencies, and this really does, that section A is full arrest. There's no pre-arrest in this section, okay? Now the second section, section B, this is for medical interventions. This means a pre-arrest situation, where a patient has a pulse and is breathing. Now, in that section, you choose one box. You either want comfort measures only, which means allow natural death. You want to have a little oxygen. You want to have something for pain or anxiety, but you don't want the other. You don't want ventilation or any of the other kind of technologies that we can apply. You want relief for pain and suffering, and the patient prefers no transfer to the hospital. Okay, so it's really symptom management here. The second one, so if you look at it, it goes in order of stop, yield, go. So if you think about it that way, so A is underneath that, you don't want anything. The second part there, the other choice is limited additional interventions. So in addition to the comfort care, in the green, the red, then you also want other medical treatments. Maybe you want antibiotics, you want some IV fluids, you want something that's going to make you comfortable, and you may well wish to go to the hospital for further comfort measures. Okay? So that's the second box. The third box is when you want everything, for the most part. You want intubation, mechanical ventilation, you want also the comfort measures and the parts in the second box. But the third box means, you want life support measures, intubation, intensive care. You want all of it. You want everything that is available and appropriate for your care. Now, the fourth box down there, it says additional orders. And we put this on there with a very small line for that purpose, is that we don't want everybody to start, writing all over the form about additional items. So again, this is a physician order, so you want your doctor to go through it with you or your loved one and write just those things that they want. Maybe they want, dialysis, things like that, or they don't want. Those are the things that you would write there. But it's very small for that purpose. Okay, and we're going to have some time at the end for some questions. Now, Part C is new as well to this form, and it talks about nutrition, artificially administered nutrition. I should go through these. Again, think about the stop line for those sections. We did medical interventions. So this is another way to look at the form. If you want CPR, you're going to get full treatment. If you don't want CPR, then you get these other comfort type measures that are there. You get those choices. I think this one's really looking at about hospitals and institutions. All institutions have their own way of writing orders or transcribing orders, right? So if this comes into your institution, you have to have some way of documenting that according to your policy. So, for example, at UIC, we have an electronic medical record system. So even though we put this in the chart for us to see, the order has to go in the electronic medical record. So this has to be transcribed into an electronic order. So again, you don't have to use this as your DNR order, but you can. A lot of nursing homes do use this in and of itself. So now we move on to section C, the artificially administrated nutrition. Now nutrition by tube, and I think there was a picture earlier of all the different kinds of tubes we can use for feeding and hydration. Now some people may say, I don't ever want a feeding tube. Okay? And again, it's up to the directives of your Catholic institutions how you deal with that in your institutions and how your patients who are Catholic are going to deal with these kind of decisions. Some folks will say, I'll take a trial period. And if it doesn't work, and I'm not going to benefit from this, then you can stop, okay? And so those are the areas under C. Or some folks will say, I want it all forever. You know, so it's just their preference there. And again, if there are Catholic directives that your institution would facilitate, then that's where that conversation would take place there. A lot of folks at UIC, if they are Catholic, I ask them if they need to see one of our Catholic chaplains to have that discussion with their own priest, because that is something that I can't counsel them on except for the medical issues related to feeding. Okay. Section D is just now the documentation of the discussion, and this is really important. So you have to check all the appropriate boxes. So it's either the patient or the parent of a minor, the agent under healthcare power of attorney, or the surrogate decision maker. Okay, who's going to document this kind of signature? Then the signature of the patient or legal representative. This may be a guardian, or it could be the power of attorney, or the surrogate, or the parent if they're a minor. And then we need that dated. Then the witness to the consent is important. And this is just witnessing the signature. It doesn't have to be witnessing the process, because as we know, this form may take several folks to help fill out. You might have social worker involved, the chaplain, the doctors, the nurses, maybe an APN. So it doesn't have to be the physician that facilitates the whole document, but the signature of the witness has to be identified by the form as well. And the witness in the statute is the same as the power of attorney. They have to be over 18. They cannot be the direct provider, which would be the any physician, and they cannot be the owner of or the director of a nursing facility in that respect. So anybody else can witness the signature. And then we have to have the signature of the physician and the date. And the dates are important because if we get multiple copies of different forms, we always take the most recent form as the valid form. Even if they haven't rescinded the old one or torn it up or written on it, we would take the most recent date. Okay? Now the requirements for a valid form, only requirements that we need is the patient's name, Section A, which is the resuscitation orders, and the signatures. So if all you wanted to use this form would be to have a DNR order, like the current or the old form, then you would just do Section A and the signatures, and you'd leave everything else. Okay? The pink paper is recommended to enhance usability, but if not, white paper is fine. Now, just like all other orders, we do accept photocopies and faxes. Okay, so, especially when we get those from nursing homes, sometimes they'll fax us the form if they're from some other institution. So we can accept those as long as we can read the choices. And again, POLST should not be used as a checkbox form or as a replacement for the conversation between patients, families, and providers. It's really to identify the goals of treatment, and that's a conversation that has to be had between the patient and the providers, or the surrogate and the providers. So it isn't really meant to be a very quick checkbox. And it's looking at making informed choices about what they want in your end of life. And this conversation should also be documented in the medical record. So it's just like any other informed consent. We get consent to apply for things. But we also have to support those discussions with the project or some other way that you would document that conversation. Now the reverse side, if you look at the reverse side, it's an optional side. There's a lot of information there, and you can do this on your own. The bottom half is really helpful. It gives you a little bit of information on what to do if you're reviewing it, if you're voiding or revoking. Now, the question comes in too, when you get these orders, you're getting orders from docs you probably don't even have never heard of, have never met, they don't have privileges in your institution. What do we do with those? Well, by statute, we have to honor those orders. But what you can do is, in the old form, there was a spot on the back that you could have a discussion and date and initial it. You can still do that here. It's just a little less, formal in respect that it doesn't have a section. But if you feel comfortable talking it over with the family, then do that and just initial and date it so that, it looks like you reviewed it with the family. And of course, anytime the patient status will change, you revisit that as well. But that's just part of the state statute. If we look at a form and it looks valid, it's got all the signatures and everything on there, then we have no reason not to believe that it is a valid form, and we would honor that as well. If it doesn't have signatures, then that's a whole different ballgame, and you have reason to challenge that form. But otherwise, by statute, even if you don't know the doctor, you have to honor that order. The older form, as we said, you can review that with them if they bring it in, and then maybe ask if they'd like to update and fill out a new form. It's more useful for them. I'm going to stop now and let Amy speak to a few items, and then we'll have time for questions. Okay? Thank you.
Thanks, Lisa. Is this on? Can you guys hear me?
Yeah.
Okay. I'm just going to go over a little bit of the Catholic moral tradition in terms of POLST. There's been some question about whether POLST is consistent with our Catholic moral tradition. And from the get-go of building this form for the state of Illinois, ICHA has been invited to the table to help build the form. They wanted our input from the beginning, which is wonderful. So we've had say and people at the table to help make this consistent with our tradition without having to kind of rail against it once it's already existed and try to get our opinion heard. So POLST, again, is a document that we look at from a Catholic tradition, hopefully that affirms human dignity. One that gives us at the end stages of life or after a severe accident or becoming more frail, advanced dementia, the ability to, as stewards of our body, tell our loved ones and our healthcare providers what to us is excessively burdensome. This document really does give the person the ability who is starting to lose the ability to speak for themselves that voice. This is something we haven't had in the past except for through power of attorney forms, which is really nice, but this is a physician order that then follows the patient into their home, into their skilled nursing home, into a nursing home, where if something emergent happens, their voice is heard. Again, to cover who speaks for the patient if the patient can't speak for themselves, we look to the power of attorney form and the Surrogate Act to help us fill out a form like this, as we would have in the past with any other kind of physician order, where there's the opinion of the patient is very important. Again, also to note, when we talk about patients speaking for themselves or having a proxy speak on their behalf, we expect that Catholics follow our moral principles and follow the wishes of the patient simultaneously, okay? POLST is really helpful for patients, again, and I keep reiterating this is for mainly emergent care settings, whether it be the nursing home, do we try and leave the patient there and make them comfortable for their wishes? What happens when they get to the ED? Are they rushed through the ED, put on advanced life support, and sent to the ICU when this is in their patient's mind excessively burdensome? It really helps to prevent patients from being submitted to those interventions that they find too burdensome. This is how it should be filled out, again, by the patient. Another question that often comes up is this a form that can be used to promote euthanasia or assisted suicide? First of all, not only is that illegal in the state of Illinois, it's also immoral. And this is not the use of the document. There's some fear, of course, that people can use this to, in a corrupt fashion, that physicians could potentially fill this out without, with the idea of ending a patient's life earlier. Of course, all physician orders are subject to those kinds of things, but we assume because we have healthcare teams, we have, witness signature, physician signature, patient signature, that there's a lot of protections built into this form so that the patient's wishes and value systems are really heard. Can we guarantee that? Of course not, but I'm a little naive and don't think that physicians often wander around doing that. So it might be a concern, but I think it's not a really strong concern because there are a lot of protections built into the form. Also, yes, it could be coercive. The form could be filled out for a patient. That's why we have the witness signature built in, so that the patient, when they're signing it, or their surrogate or proxy power of attorney, that they are able to say the patient has read through this form and understands what they're signing. That's why the witness is there. I think that those are the main things that are kind of bring up concerns within Catholic healthcare and our moral tradition about the POLST form. Of course, there are other concerns. Dr. Eli addressed potentially antibiotics, which we don't address. And of course, artificial nutrition and hydration comes up. The way that the form is written gives us every ability as Catholics to fill it out, to follow our value system, to follow the ability to provide nutrition and hydration when appropriate, or not provide it when not appropriate. It also, I think, something that I really am proud of that's on this form is the fact that it says that to offer food if by mouth if feasible and desired, that we are always offering nutrition to a patient. Maybe it's not enough nutrition to support great caloric intake, but we're offering food, which is extremely important and documented. I think that now, also, something else I was asked to talk about was what are the Illinois bishops, are they informed on this? Have they commented on it? At this point in time, the Illinois bishops have been made aware of the document by the healthcare vicar for the Cardinal, Father William Grogan. The Archdiocesan Bioethics Committee has reviewed the form, and we're waiting for a statement from the bishops. There hasn't been any feedback at this point. Their healthcare vicars are well informed and are helping to educate the bishops, and so that they can have a discernment process and decide, what their thoughts and evaluation of the form is at this point. So I just wanted to open it up to questions.
Yes, first, I don't know if I'm ready to hear me. I first just want to commend you on what I think is a super job. The way you just presented, both of you, that was crystal clear. And I was really thankful to stay to be able to hear all of this.
I wanted to say, though, that in the past 6 months, I've been approached many times by all these people with beefs about POLST within the Catholic community. And I really like the way you just explained all that in keeping with Catholic doctrine. And I just wanted to ask if you had also been kind of put in the midst of kind of like, I thought it's an unnecessary controversy about all this. People are asking me, Dr. Ely, are you opposed to POLST? And why would you be in favor of POLST? But in the ICU, this is a great thing for me because people come in, I have no idea what they're thinking, and I'm always guessing all the time, and now I know what they're thinking. So have you also been confronted about this as if it's like a controversy and a railroad towards euthanasia a lot, or are you just made aware of that a little? And were you included in the conversations that the CMA is now creating a white paper about POLST and that sort of thing?
As far as the degree of controversy, I think we're actually very prone to that. The state of Wisconsin, the bishops have come out with some less than positive recommendations regarding POLST. But something that's really important to understand is that POLST is a state-specific form. And the POLST form as developed in, say, Wisconsin is not the same as in Illinois. And as Amy mentioned, we have had Catholic healthcare at the table from the inception of the work. And so there has been incorporated a lot of those protections. For example, unlike some states, in the state of Illinois, the patient or their legal agent must actually sign this form. You cannot have a physician sign it without the patient's knowledge or consent. That's been one of the objections that's been raised. So there's been a number of those protections built in.
I think that if I might just put on the table what the controversies seem to be and then let you address them. And then after that, I have to go catch a plane, so don't make me rude when I leave. I'm not disinterested, I just have to go to the midway. The things that they keep bringing up as controversies are a non-professional facilitating the signing of this. So, excuse me, not a non-professional, a non-physician facilitating the signing. They are professionals, but non-physicians.
Right.
And then the second of the three controversies that I've been asked about is the inclusion of antibiotics, which I'd like to hear your story about how you didn't include it, except in that second bullet point, which was nice. And then the third one is, of course, the nutrition piece. So the doctor part, the nutrition part, and the antibiotics part seem to be what really get everybody ruffled up.
We obviously were well aware of, when we were writing this form, what the Wisconsin bishops and even the Minnesota bishops had said about POLST. Some of these protections were already built in by law, like the patient signature, the witness signature. We're trying to get in front of it instead of having it be a reaction, that we're addressing these issues up front. The nutrition and hydration, we just talked to a lot of Catholic ethicists and theologians to try and make sure we were all on the same page, because we knew we'd be answering these questions. As far as the antibiotics, that was actually the entire form writing committee was uninterested in adding antibiotics because it wasn't really something that was happening really outside of the hospital in terms of emergency management or management of a patient in a nursing home. That we were really addressed. That wasn't so important to be built into this form.
If I could jump in on that, actually the experience with POLST nationwide has mitigated the use of antibiotics on the form. The first form was in the state of Oregon, and they had antibiotics as a specific section on that form. Every year, the form gets reviewed for appropriateness, for updates, etc., by a statewide task force. The state of Oregon removed the antibiotic section because no one was using it. So it's really a non-issue.
Well, and just to let you all know that we did have a statewide task force. We still have that in place. We have like conference calls, we have emails. This again, Julie Goldstein, some of you know her from Illinois Masonic. She's been working with this particular project since the Orange Form, so that's been over 10 years ago. She's compassionate and very passionate about this, looking at palliative care. But we also have a lot of subgroups, education. We're going to give a lot of support through some grants that we've written with our leadership roles. So we have some money to make DVDs that'll be available to all, and we're going to do a good job with that, like the California one. They have this wonderful DVD that they send out to all the institutions for education. We're currently doing a couple of pilot studies right now. We have 3 sites throughout the state of Illinois, 1 up here and 2 down in central and southern Illinois, where we're actually filling out this form, because we know we're going to revise it, in 2 years. So we're trying to be proactive with our committees, our education subcommittees. We've done lots of train the trainers, and we're still doing those as we speak. So again, it was a very thoughtful process, and we're also looking at evaluation. Let me just throw this out there and ask the question: how many of you know what the statistics are on the state of Illinois Orange DNR form? The old form, how many DNR forms do we ever get? Do we know the usage? Is there been problems with it? The state doesn't know. There was no built-in evaluation. We often in Illinois put things in motion and we don't have any way of evaluating or seeing if it works, how we can work it better. So we've kind of uploaded the evaluation process. We have a task force that's doing that right now. So if you have suggestions, kindly send them to me, Julie Goldstein, Amy, because again, this is our form, this is our state form, and we want it to be useful to not just the patients, of course, but to the providers, the family. We want it to be useful for everybody. So, you know, sometimes we've looked at this form so many times that we miss the obvious, right? So if you see something, we've already got a few comments that we'll put on the board.
Father?
I'm not sure if I could put it into a question, but it's certainly a comment from a pastoral perspective that I'd like everyone to consider if you are with sick and dying. I would just say we should never underestimate the power of the holy person who dies. And in that sense, that affects these decisions. If I could put one more box on this form, I would put it something like the Saint Monica syndrome. That is to say, Saint Monica, the mother of Saint Augustine, wanted to live to see her son convert, to accept Christ. And after Saint Augustine converted, she was much more at ease with the idea of leaving this world, since she knew her family, her son was on the road to heaven. I've seen people convert when they go to visit their dying mother or grandmother or wife. Those people who are close to God at the end of life, a few words to them. Sometimes my mother's last words, my mother's dying words were, "Go to church." Oh, I better go to church. I better change my life. Now, that's hard to put into this form, but as believers, we are believers here, as believers in the ultimate reward and the ultimate punishment, those things should be a part of this decision, helping others prepare for the judgment, prepare to see God.
And that's our hope, is the form, as it facilitates the conversation, you know, from our moral tradition and our faith-based vision, that it facilitates all kind of conversation, maybe with family or with a pastor, so that people are not just talking about the medicine, but talking about their life values. Yes?
We recently had a presentation from Dr. Goldstein to our team about the POLST form, and she said that as far as the witness goes, we work in home-based palliative care, and having a witness that isn't us is most times impossible because it's the patient and I doing the form. Is that built into the law? Because it's my understanding that it's kind of institution-based. If they decide if the, you know, as a healthcare professional can witness the form or not.
It is, as long as you're not a direct provider, right? If you're a direct provider, you cannot witness the form.
And that's in the law?
Yeah. That's part
Provider,
of the statute.
I think the statute, it's the physician. Now in Illinois, we don't have APNs. If you notice, the advanced practice nurses or PAs cannot sign this order. And that's something that we politically had to put on the back burner from some pushback we got from ISMS, the Illinois State Medical Society. So that's a question will come down the road. But we know in Southern Illinois that a lot of the APNs are doing these kind of things. So in the statute also, I mean, we can do phone orders. So we will accept phone orders that, you know, so again. But I think the law says they cannot be the owner, director of a nursing home, the physician, the attending physician, or it'd be 18.
Yeah. But it could the bedside nurse sign it? Yes, absolutely. So you would be, unless you're a physician or you own healthcare.
And think about the conflict of interest. There's no conflict of interest for you to witness, okay?
I have a question. What do you do when a patient arrives in the emergency room, has been resuscitated, is on dopamine and intubated, and then the family shows up with this form or an advance directive that contradicts the treatment that's already been administered? What do you do?
You have a quality conversation and make a medical plan from there. with the family and say, you know, this is clearly not the wishes, this happened because EMS showed up, didn't have the form. Either let's continue with this treatment plan because it's going to be beneficial, it's just a slight pneumonia, let's get him through this and see how he does the next 2 days, rehab the conversation, or, whoa, this is really aggressive and isn't meeting the patient's wishes.
No offense, Amy, I know your position. I'm interested in the position of the rest of the panel.
We stop and withdraw everything. I've had that happen once or twice.
That's what you do at UIC?
That's what my
With-
experience has been.
Without consent to withdraw life support, you just withdraw it?
If someone comes with a DNR order that we weren't aware of, we palliate withdrawal. Because what we've done is battery, we've done something against them that we thought was the right thing to do, but in turn it wasn't. And we've had a couple of cases in Illinois where something like that happened and it was a huge award about money. So it's really looking at what is the dignity of that person, what did they want done to them. You know, we unfortunately did things because we didn't know, but at the point where we find out, then we have to pull back.
So POLST will continue to have many questions that it will produce, particularly as we try to provide the best care for our patients and moral care for our patients, which is what our objective was for today. So thank you very much to our panelists.